Hello and welcome to the Headache Doctor podcast, where on this podcast, it's our mission to educate and empower everyone with headaches and migraines so that you can break free from a life of fear of your next headache or migraine and dependence on medication. In today's podcast, I teed this up probably a couple weeks ago. I talked about chronic pain, and I said that we're going to have a provider on that is an expert in chronic pain, and this is how she set up her practice. So we have Dr. Carrie Beall. She's out in Michigan, and she is a specialist when it comes to chronic pain. And I connected with her through a mutual kind of friend connection, another professional. And I think this is going to be a fascinating conversation because most of you listening are dealing with chronic pain as it relates to headaches and migraines. So I'll refer to her as Dr. Carrie, but Dr. Carrie, thanks so much for being on the podcast.
Thank you so much for having me. I cannot tell you how excited I am to talk to you.
Yeah, so I would like to start off, as I normally do with our podcast guests, with just giving you a platform to kind of orient people to who you are and your background, and then how you got into this space of chronic pain. So go ahead and give us a little bit of a snapshot of your story.
Yeah, thank you. And I also want to say that you have a very well-educated listener base here. I've listened to many of your episodes and just love it. So, all right. So yes, I am a practicing osteopathic physician in Michigan. I specialize in treating chronic pain, and I use an osteopathic approach, which is mind, body, and spirit. So I'm really big on not using medications, not using things that aren't really necessary, getting to the root cause of what's causing people's symptoms. Typically, it's chronic pain related, including headaches and migraines, tension headaches, and really just focusing on how I can best alleviate and treat their symptoms at the root cause.
Yeah, that's fantastic. Give us a little insight into when you say an osteopathic approach, you have DO behind your name, correct?
Yes.
Yeah. And so what does that mean to the layperson that's trying to understand, like, how is that different than MD? What is the training involved? That sort of thing.
Our training is mostly the same now. It has kind of changed over the years. It's been 150 years since the osteopathic profession was born. And it really, we focus on treating the whole person, mind, body, spirit. And we get a lot of extra training in the neuromuscular system in school. So that's a big difference in our medical school training. We do also learn osteopathic manipulation, which is hands-on diagnosis and treatment manipulation of anything in the body, including the head. And then going forward with that, I did specific osteopathic residencies and fellowship training. And so I had a little bit extra of that, the osteopathic principles through that training as well. So really it's mind-body approach, and taking into consideration the entire person as a whole.
Yeah, I love that. And that's such a needed perspective in our healthcare system. Well, take us through your career so far, and what led you to wanting to pursue kind of specializing, or at least focusing on chronic pain.
Yeah, it's been a little bit of a roundabout, I suppose, direction. So I actually started in athletic training, and that was my undergrad. And I've always had a love for sports. I was an athlete myself, and found myself injured at 16 with my first back injury. That was the start of my chronic pain journey. And in the athletic training world, we worked with osteopathic physicians. I loved what they were doing and decided I wanted to go to osteopathic medical school with a goal of doing sports medicine. And so I took the primary care route. I was a primary care physician for 8 years, also worked with athletic teams from the recreational level, covering, marathons, triathlons, those kinds of things, high school, college. I worked with a Division II college, and also professional, working with professional hockey team. And actually, I also work with U.S. figure skating, so on the international level. So from there, I transitioned to practicing all osteopathic manipulation. And that is where I developed this kind of newfound passion for treating people with chronic pain, because that was probably about 90% of the patient population. It was chronic pain related. And at the same time, I conveniently was having a flare up of my chronic back pain and not finding the answers I wanted through the typical avenues. I'd had multiple epidural injections, and it just wasn't the right thing for me. And so that's how I discovered this mind-body approach, and the neuroscience behind mind-body medicine. And through using that for my own chronic pain, I fell in love with the science. And when you marry the patient care with the science, you end up with treating people with chronic pain, in my world anyway. So now I have my own practice where that's all I do is osteopathic manipulation, some dry needling, and pain reprocessing therapy for chronic pain.
Yeah, that's amazing. So when you say osteopathic manipulation, it's a hands-on component. Tell us a little bit more about that.
Yeah, there are a lot of different techniques that fall under the umbrella of osteopathic manipulation. I tend to use the gentler techniques. We certainly learn the popping and cracking we all think of with manipulation. I don't use a lot of that. So it's moving fascia, muscles, joints, to positions of ease, or sometimes into the barrier to correct alignment issues and improve range of motion.
Yeah, that's fantastic. So when it comes to neuroscience, mind-body connection, like you mentioned, tell us more about that, whether it's like your personal journey or just, maybe at a high level, what that even means to the listener when we try to understand pain and how, I mean, are we thinking about pain differently? Is there something we need to know about pain? Kind of bring that into reality for people.
Yeah. And you did an excellent job in your chronic pain episode. If anyone hasn't heard that, it's so good, because the examples that you give, it just makes it make so much more sense. So, all pain is real, and all pain is processed in the brain. And no matter if it's like in your example, stepping on a nail or twisting your ankle, it's still how our brain processes those signals from the body. And so, depending on how our brain is processing that, we might feel different sensations. Or in your example of spraining your ankle and I think it was a bus, trying not to get hit by a bus, you might not feel it at all because your brain's like, we got to get out of here. So, so our brains can also then learn pain, just like we learn how to read and ride a bike. Our brains can learn these pain loops, and then start creating the pain even when we're not having pain signals. And you talked about hypersensitivity. That's exactly it. These pain loops get triggered with things that typically we wouldn't think of as generating pain, like maybe light touch or even just thinking about something that might be painful.
Yeah, so we have this element of the pain being kind of a subjective experience. How do you match that? So in your practice, you're using hands-on techniques, and then you're implementing this. Is it mainly an educational component, just orienting people to what they're feeling? Is that correct?
That's the beginning stages.
Okay.
And then there are a set of techniques that I take them through called pain reprocessing therapy. And that is the rewiring of the brain. So taking those learned pain loops and rewiring to new brain or neural circuits that aren't painful. And then also at the same time, even if it's not a learned pain, let's say it's just hypersensitivity, pain scale is really dialed up. It helps dial down, or just turn down the volume on the amount of pain someone is experiencing.
Yeah. Okay. So rewiring. What is that? This might be a hard question. I don't really know. What does that look like practically? Is it just reframing how someone's understanding their pain? Are there actual things that people are doing when they're in pain? Can you give us an example of like a recommendation you might give someone?
Yes. So to answer your first question, yes and no.
Okay.
It is some reframing. There's certainly some cognitive pieces of this where we're looking or thinking about things a different way. And then we are also using our conscious brain to retrain our unconscious brain where these pain loops live. Because
Okay.
it's not like we're wanting to have this pain. When I think, for me, again, it's back related, but when I think about bending over to pick something up, I'm like, oh, my back's starting to hurt, and I'm just thinking
Right.
about it. So clearly there's no damage happening there. There's no tissue damage. So I work to rewire something like that, where the action, just thinking about the action and then doing the action, leads to pain. And so it's conscious and unconscious rewiring of the brain.
Right. So over time, individuals will associate, and like in your example, there is something physical that is either irritating or causing some sort of tissue damage originally.
Yeah.
But as time goes on, that association with bending over may not actually be leading to tissue damage, even though they're having the same experience. Is that correct?
That is exactly it. And it feels the exact same, which makes it so difficult to identify, because for years I was like, no, that's my disc, that's my nerve,
Right.
and it was not. So it was originally, you're right. There was a disc herniation and tissue damage, and then that no longer was the case.
So let's talk about how this presents in your practice. When you're talking to an individual that's going through headaches, migraines, and we could even use any type of pain. I don't think for our audience it necessarily has to be specific to headache or migraine, but if we have an example, that's great. But how do you, when you're interviewing someone, when you're going through and getting their history, what are some things that pop up that make you think, okay, this is probably more mechanical and I'm going to do more hands-on, or this is, no, like we actually need to do, what's the word for it? Like retraining, because you said it's a little bit of reframing, but you said there's that process as far as pain science. So how do you distinguish between those two?
That comes from both the history and the physical exam.
Okay.
So with the history, we start to see some frequent patterns. And the patterns, they can overlap with patterns that look structural. So sometimes this is a little bit of, we treat both things, or we treat one thing and we see kind of what teases out there. And honestly, I think there's usually both. So we've got our functional or structural component. And when this has been going on for 6 months, 5 years, 10 years, there's also some learned pain pathways there as well. So things that are all one side of the body, or symmetrical. And again, knowing that it's not an inflammatory condition, or, like rheumatoid arthritis or other things that can look like that. Things that are precipitated by emotional stress or mental stress, or thinking about stressful things. Another thing is predicting it. And so, like I said, I'm going to have pain if I lean over and pick this up. So someone might say, oh, there's a cold front coming through, or there's some pressure changes coming in. My knee is hurting. My head is hurting. whatever, the body part
Right.
is, they're already predicting that pain is starting. And a lot of times it'll start before the actual trigger even gets there. So those are some of the more common ones. There's a whole list of criteria that I take people through, and then the exam findings. So with, let's say with neck pain, really common to have neck pain with a certain movement. So we test that movement. Great. Okay. So now we push on the spot. So let's say it's right here. So I'm pushing on the right side of my neck. So I push with about an ounce of pressure and I start having pain. An ounce of pressure isn't really causing tissue damage, right? So that's a clue. Then I just float my fingers on top of it. So I'm not actually pushing. I'm just thinking about pushing my finger down on my neck. And that causes pain. That's another clue. And then I push really hard. So now I'm like really digging in there, and either it doesn't hurt or it actually feels good. That's another clue. Not tissue damage, because if that was tissue damage or, something, and again, these aren't motion tests, so we're not thinking functional here.
Right.
But that should actually hurt if I'm like really digging my thumb into a spot. So those are some of the exam tests that we'll do.
Yeah. When you said pain on one side of the body, you're meaning they have head, right shoulder, elbow, knee, like there's multiple sites of pain on one side of the body. Is that correct?
Correct. Yes.
Okay.
Not like migraine, like, typical migraine neck pain connection. Yeah.
Right. So not like, oh, my headache's always on the right. Yeah, that could coordinate with something physical, as opposed to just having multiple sites that aren't connected. Yeah. Okay. How do you, what I'm curious about is you mentioned this thought of someone bending over and they think, in your scenario, you think this is my herniated disc in my back, right?
Yes.
Or at least you thought that at one point. What do you think in our healthcare system? There's multiple questions here. So you got into this because you're like, hey, there's a gap here. This needs to be this type of treatment needs to be provided. So why? Why are you seeing that? Why is that there in our healthcare system? But the second thing is, what damage might the way we're communicating to patients and describing their symptoms, what damage might that be doing to like what they're actually picturing in their head? Do you understand what I'm asking?
I think so.
Okay.
There's a very specific example with that I frequently use, and that's telling someone this is the worst, and we do this in medicine. I used to, not anymore.
Yeah.
It's the worst MRI I've ever seen. And we think we're validating their neck pain because they have some disc degeneration.
Right.
But that's not helpful, because then someone, attaches their symptoms to one specific thing that probably doesn't actually have a lot of weight into why they're feeling the way that they are. It's probably more the way that they're moving or a learned pain process or something like that. So that is actually, that's a big one for me. I'm like on a mission to teach other providers that those kinds of things, while we mean good, we're trying to validate someone's symptoms, it's actually not helpful. So yeah, is that kind of what you were asking with that one?
Yeah. And I think people listening are connecting with that. I would imagine so, because a lot of the people we interact with have gone through imaging, X-ray, MRI. And I actually just got off a call with someone earlier today where I told them that in our healthcare system, you as the individual with a headache or migraine, you come to them and you say, this is my problem. And they're sitting on the other side thinking, well, what tests am I going to run? And then they run those tests and they're just looking for something that maybe connects. And when they find that thing, they sort of go down a rabbit hole of, well, this might be causing it. And oftentimes unfortunately in our healthcare system, it's like really invasive stuff. Like it could be, It could lead to a fusion or like, some surgical procedure, injections, not little things. And oftentimes, like if we took a totally healthy person, I'm going on a tangent here, but if we took a totally healthy person and just imaged their whole body, we'd probably find stuff, but it doesn't mean it's connected to their symptoms. And so, yeah, I think that's exactly right. We put images, like literal images, but also like in the words we use, we might be doing damage in when it relates to pain and how we think about that. Are you having to reframe a lot of this for people?
Yes. And I'm sure you hear this all the time too. Like, someone comes in and I say, what brings you here today? Or I see you're having some neck pain. And the first words that come out are, I have degenerative disc disease, or I have bulging discs, or I have facet degeneration, or, it's not, my neck's been bugging me. It's the findings from, their imaging. And so it is a lot of reframing. And, yes, they have those things, and that's probably not where their pain is coming from. So that is a challenge, and it might be selfish that I'm trying to change the wording that people use because it would make my job easier. But also I think it's in the best interest of patients so that they can get to the root cause and treat the problem at its core and not be running around in circles trying to fix degenerative disc disease, which is like wrinkles. Like wrinkles aren't painful, Right.
Yeah. Okay, so I think you and I think similarly because I think I've talked about it on the podcast, but when there's two sides of the spectrum. There's providers that like lean heavily, and this is kind of what we're talking about, but lean heavily on the like imaging, the testing, and then it's just like you're identifying with your results. Like I have degenerative disc disease. Like, and when we interact with them, like that's what they say. They're like, well, I have a bulging disc. And then there's providers where it's like, well, we just want to make sure you feel good. And I tend to lean on the side of like, what are your symptoms? And even if someone comes in and like objectively their neck might feel tight, like if they feel okay, I tend not to like create a problem when there's not one. And a lot of that has to do with like pain science and how we experience pain. Do you agree with that? Is that something that you would
yes.
you implement? Okay.
Yeah, 100%.
Okay.
Yeah.
Yeah. I think I'm also curious, like, so going through your objective testing and things like that, how do you how are you communicating? Are you using a lot of examples and stories? Like if someone does bring their imaging to you, what types of conversations are you having?
Yes, and yes. My favorite is a study that was done in 2015, 2017, somewhere around there, on over 3,000 people without back pain, and ranging 20s to 80s, and they were delineated out by decade of life. And all the findings in all of these, I think it was 3,300 people, all the findings on their lumbar MRIs, and these were all asymptomatic people. And the amount of degenerative disc disease is just like astounding. And it talks about other findings as well, facet degeneration and spondylolisthesis even. So we know that these things exist, as you said, in people. If we were to MRI everyone head to toe, we're gonna find all these things. So I like to bring up that study, and I will actually show them the number of people in each decade of life. So that's a big one. I like to talk about the wrinkle analogy, especially when it's degenerative changes, because we all have wrinkles, we all have scars, our scars on our skin. Those aren't painful. So when we talk about like scar tissue, oh, you've got scar tissue in, wherever. And it's like, well, does the scar on your arm hurt? No. Well, I'm not sure the scar inside is really hurting too, unless there's some active inflammation, but that's not what's happening here. So, so I like to bring examples like that. And then that testing that I talked about, that physical exam testing, and that I will actually do with people just over Zoom, because they can test themselves with those. That's another one where it's like, if that hurts and you're not quite pushing on it, wonder what could be causing that. So those are the big ones that I like to use.
Yeah. Yeah. As far as understanding pain and taking someone through this process, I guess I'm curious, what type of impact are we talking about here? Taking someone through this, I'm going to use the word reframing, but taking them through this education of their pain and understanding how pain is realized. What is the impact you've seen that have on your patient's situation? And then, like, in particular, headache and migraine patients, but just in general. So, meaning, obviously, you're doing some hands-on component, but if you never touch someone and we just educated them, what kind of impact could that have?
It's very interesting. It's there's a name for it, like the book effect or something, where someone just reads about this, and there are a lot of books out there about this, and they're suddenly better. So sometimes it is just a reframing and just learning that knowledge is power. I like that you say that. And sometimes that is enough. And then when it's not, it's usually because we need to convince that unconscious part of the brain a little bit more. And then that's the rewiring. And it is, I love watching people go through the process, because you just see their face light up, and just knowing that they have so much time left in their life that is now going to be enjoyed and not suffering because of whatever condition they might have.
Yeah. So, right, there's different layers of this. I had a patient one time tell me that he saw, I think it was a DO, and basically the DO said that, like, this isn't a neurological problem. Like, you don't just have to suffer with migraines. Like, your neck is causing this. And that's all that happened in the appointment. Was the DO said, the physician said, this is coming from your neck. And the guy, like, felt tremendously better because he realized, oh, I'm not dying.
Yes.
But you're saying, like, that's, like, probably the lowest hanging fruit. But then there's people where their subconscious is so attached to it, you have to retrain how they're subconsciously interacting with their pain. Is that correct?
Correct. And it's the subconscious is the wiring, the learned pain pathways. It's much deeper seated. Yeah, like you said.
Yeah, and then give us an idea of, like, how much time that might take someone.
That's a hard one, because some people, it is just that education, knowledge is power, flip a switch, I feel great. I would say most people, by the third session I have with them, they're feeling a significant change. And, a lot of this has to do with how often people are actually doing their homework, the exercises. It doesn't take a lot of time. It's more about repetition and short snippets of practice versus sitting down for a half an hour to do something. And then usually by 6 to 8 weeks, and again, it just depends on what they have going on, how deeply seated these pain pathways are. They're doing significantly better, and they're able to just continue the training that I've given them on their own. Yeah.
When we're talking about years or decades of pain, when we say weeks, in weeks time or months, it's like, that's nothing, so relatively quick turnaround. I love that. Tell us, because I think there's going to be people listening to this that think, I could benefit from it. And so I guess first question would be, is there a specific type of scenario where you see, like, this form of treatment is especially important? Or is it more like just anyone that's dealing with chronic pain? and maybe we need to define what chronic pain is, but.
Yeah, I think it's going to be anyone with chronic pain, probably 6 months or more,
Okay.
Because that's about how long it takes for people to start having more of an emotional component to it. So they're frustrated, or they're fearful, or we talk about the F's of resistance. There are 6 of them. So fear is probably the biggest one. And I think you talked about that in your chronic pain podcast. Fear just cranks up the intensity of how our brain produces pain. And so fear, fighting it, frustration with it, trying to fix it, but in that roundabout way, not actually getting to the root cause and then working on it, but this, fixing the wrinkles, kind of fixing, figuring it out. So that is another thing. And I'm not saying that trying to figure it out is wrong, but I am saying that when we are trying to constantly figure something out, that's going to dial up the intensity of the pain. And then focusing on it. So pain scales are another thing that will actually turn up the intensity of pain when we're really focusing. Okay, did this hurt? Did that hurt? And I think I listed 6 there. So yeah. So what I try to do is aim my treatment at the resistance, because pain times resistance equals suffering. Pain's a given. Pain's normal, right? All pain is there's a reason we have pain.
Right. It's not a bad thing.
Right. So, but if we resist the pain, that's what leads to suffering.
Right.
So if we can decrease resistance, anything times 0 is 0, right? So pain times no resistance, no suffering. So I really try to aim my treatment at the resistance.
I love that. Well, I think the next question is how can people interact with you?
I think the easiest way is through my website, serenityosteopathicmedicine.com. I am practicing in Michigan, so I can see patients on a medical basis in Michigan. And then I also have a coaching program, which is purely for the chronic pain side. So that's coaching those pain reprocessing therapy techniques. And that you can reach me through Serenity as well.
Yeah, that's awesome. So, and you're saying the coaching component, like you can interact with people from all over, correct?
Correct. All over the world.
Okay, that's great. And we definitely have people in Michigan. I've had several that have come out for treatment from Michigan. So they're probably a little bit of a drive from you, but it may be worth it because having connections in other states is huge. Any other like tips or tricks or takeaways for people when it comes to chronic pain?
I think any activity that is calming, and you mentioned this last time as well, is going to be the best thing for turning down the fear aspect.
Okay.
So sometimes it's modalities like acupuncture, needling. I even consider osteopathic manipulation to be a calming activity. It's soothing to the nervous system. I also like heat. Heat for me is so soothing. I know it's not fixing any tissue, anything, but it just feels good.
Yeah.
And so anything that you can do that feels soothing to your nervous system is going to help dial down the amount of pain.
Yeah, I love that. And those are all very easy things. I mean, we have a little neck wrap that people get after their first session with us. And so now I can say Dr. Carrie recommends this.
Yes.
I love that. Well, thank you so much, Dr. Carrie, for being on the Headache Doctor podcast. We actually, I don't know if we fully explored the depths of chronic pain or provided people with a really valuable resource here. So I'm excited to add this to kind of our Rolodex of providers we've had on the podcast. So thank you so much for being a part of this.
Thank you so much. I just love everything that you're doing, and I'm so happy to be a part of it.
Yeah, absolutely. So for the listeners or viewers on YouTube, thank you guys so much for continuing week after week to tune in. We'll continue to provide valuable information and have other providers so that we can continue on this journey of educating and empowering everyone with headaches and migraines so you can break free from a life of fear of your next headache or migraine and dependence on medication. We'll see you next week.